Okay, so on behalf of the GAP MASLD MASH Community Network, I'd like to thank you for logging in today for today's presentation. I'd also like to start by thanking Madrigal Pharmaceuticals for sponsoring today's presentation. Today we are going to be discussing MASLD and MetALD. My name is Elizabeth Alqueza. I'm a physician assistant at Beth Israel Deaconess Medical Center in Boston, Massachusetts. I work exclusively in the field of hepatology with a large emphasis of my practice treating those patients with steatotic liver disease. I'd like to encourage you to use this QR code to record your attendance for today's meeting. I'll give you just a moment in case you want to take a quick photo of that. So we're going to get started today with a case presentation. Our patient is Ashley, and she comes into your clinic, a 52-year-old female. She was referred for evaluation of an abdominal ultrasound, which showed mild hepatomegaly and increased hepatic echogenicity consistent with steatosis. She overall feels quite well, doesn't really have any complaints. And as you can see next to her photo, I will point out she has an elevated BMI of 29.4. So right away, we're starting to think, okay, she has evidence of steatosis on her ultrasound, and she is on the cusp of being diagnosed with obesity. As you can look at her medical history today, she has polycystic ovarian syndrome, and I think important to note that 70% of women with PCOS have insulin resistance. She has hypertension and hyperlipidemia. On social history, she reports an average of 2 glasses of wine per day. On physical exam, you can palpate the liver edge, feels non-tender, smooth, no other remarkable findings. And when you look at her medications, she's taking an antihypertensive medication, amlodipine, and she's already on atorvastatin. She takes a multivitamin and milk thistle. And as I said, her BMI is 29.4. When you look at her vital signs, you notice that she has elevated blood pressure of 140/78. Her respiratory rate and temperature are unremarkable. BMI is 29, and labs show elevated liver function test. So her ALT is 46, AST 55. In the world of liver disease, I recommend patients have liver transaminases under 20 for females and under 30 for males. Her platelets are normal. Her hemoglobin A1C shows you that she's in the pre-diabetic range, and her triglycerides are also elevated. So as you think about non-invasive testing to further stage her liver disease, you decide to order a FibroScan. And I tell my patients FibroScan tells us 2 main pieces of information. One is the level of stiffness of the liver, which correlates with the degree of fibrosis or damage. I also mentioned the CAP score, which quantifies the level of steatosis or fat in the liver. In this case, the patient has a liver stiffness score of 11.4, which puts her in the realm of significant or stage 3 fibrosis. She has an elevated CAP score of 310, which makes her fall into the realm of severe steatosis. So in this case, you're starting to think, okay, this patient has some significant liver disease. In looking further at steatotic liver disease, there are several subcategories. Starting on the far left, we see our category that encompasses metabolic dysfunction. So previously known as NAFLD, we now call that disease state MASLD, or metabolic dysfunction associated steatotic liver disease. So that's your patient who comes in. They have steatosis in their liver, and they have at least one cardiometabolic risk factor. That could include obesity, hypertension, diabetes or prediabetes, and abnormal lipids. Then we have the more advanced or aggressive form of MASLD, which is we term MASH, metabolic dysfunction associated steatohepatitis. And that is, as I mentioned, sort of our more aggressive form of steatotic liver disease due to metabolic dysfunction. And those patients have histologic features on their liver biopsy that could include hepatocellular ballooning, lobular inflammation, fibrosis potentially. And those are our patients who will often progress, and we don't want to miss those at-risk MASH patients. Moving over to the right, the next two boxes deal with liver disease related to alcohol. And the large sort of central box looks at what we're discussing today, which involves MASLD plus increased alcohol intake. So this breaks down a patient's alcohol intake into weekly and daily consumption. As you can see, starting on the left-hand side of this box, for females, they would need to consume greater than 140 grams per week or 20 grams per day to kind of be considered for this category. In males, that amount is 210 grams per week or 30 grams per day. And again, if they're going to fall in that MetALD category, they also have metabolic dysfunction. So at least one cardiometabolic risk factor and steatosis, obviously. As we move over to the right and you see greater daily or weekly consumption of alcohol and potentially lack of cardiometabolic risk factors, then we're thinking we're moving out of MetALD and into our alcohol-related liver disease. That would be the disease state in which alcohol is the predominant cause. Finally, moving over into those gray boxes on the right, we have some other etiologies which could lead to steatotic liver disease. That could include drug-induced liver injury. It could include monogenic diseases, for example, lysosomal acid lipase deficiency, Wilson's disease, hypo-beta lipoproteinemia, or inborn errors of metabolism. Could fall under the miscellaneous category, which might include hepatitis C, malnutrition, or celiac disease. And then finally, on the far right is our cryptogenic steatotic liver disease, for which we don't know the underlying cause. So in thinking a bit more about our patient with potentially MetALD, I think it's important to understand what is a standard drink and what quantity would cause our patient to be considered for falling into that diagnosis. So a standard drink contains 14 grams of alcohol. And as you can see, the drinks are all different sizes and they contain different forms of alcohol, but each contains the same amount of alcohol, that 14-gram quantity, and is considered to be one U.S. standard drink. So this is an interesting discussion that I'm sure we've all had with our patients is, how much are you drinking on a daily basis? And as you can see, one 12-ounce beer is equivalent to 8.9 ounces of a malt liquor, 5 ounces of a table wine, 3 to 4 ounces of a fortified wine, 2 to 3 ounces of a cordial or liqueur, 1.5 ounces of brandy, and 1.5 ounces of an 80-proof distilled spirit. So it's important to quantify exactly what the patient's drinking and to try to get a sense of how much. As you can see, someone who says, I drink 2 glasses of wine a night, well, depending on the size of the glass, how much they actually pour into the glass, it actually may be more or less than 2 glasses of wine. So this slide looks at the key pathogenic mechanisms in dual etiology. And by dual etiology on the left, we're referring to that patient who has those MASLD risk factors. We've talked about them already today, but they could also include having extra visceral fat, having a very unhealthy diet, perhaps a sedentary lifestyle, maybe some genetic susceptibility, and then combined with the alcohol intake. And as you can see, the combination of those two sets of etiologies can lead to impaired lipid handling. So you have free fatty acid induced lipotoxicity that leads to oxidative and endoplasmic reticulum stress and cell death There's a disruption in the intestinal microbiome, and there's a pro-inflammatory loop that becomes created. This ultimately leads to enhanced fibrogenesis and disease progression. And I think whether we understand all the pathophysiology behind what's happening or not, the take-home message is that the combination of a patient with these cardiometabolic risk factors plus increased alcohol intake results in accelerated fibrosis and disease progression. So that combination is additive, synergistic, and is going to hasten their disease progression. This is based on an article in Lancet Gastroenterology and Hepatology, and the schematic looks at different drivers of steatotic liver disease, as we've been discussing so far today, and then those underlying liver disease and the risk estimate for decompensation. So as you can see sort of in the middle section of the screen, we have the first column is our MASLD, the second column is our MetALD, and finally our alcohol driven liver disease. And there's different disease drivers that may play a role in their risk for decompensation. Those could include those cardiometabolic risk factors, genetic risk factors, and obviously the amount of alcohol consumed. But I think the big picture here is that when you have MASLD in isolation, if we look at higher FibroScan fibrosis scores, you can see that there's a 5 to 15% risk of decompensation at 5 years. Moving into the patient who has MetALD, that risk becomes double. So they're now at a risk of 10 to 30% of decompensation at the 5-year mark. And finally, moving over into alcohol liver disease, there's a bit more variability, but still increased at 15 to 50%. So once you add the alcohol on top of the metabolic dysfunction, you can see increased or shortened time frame and an increased risk of decompensation. So this image is from a study and is kind of introducing us to the idea of detecting alcohol use through biomarkers. This was from a study in the Journal of Hepatology that looked at fatty liver disease and then tried to employ different methods to see the validity of using a biomarker to determine alcohol consumption. And that first column on the left shows our fatty liver disease risk factors: alcohol, diabetes, obesity, and diet, and shows us the progression where a patient can have steatosis alone, have the additional risk factors, and go on to steatohepatitis and potentially progress on to cirrhosis. And so this study looked at alcohol intake through a variety of methods. A questionnaire, the Audit C, was given to these patients. They had some blood work done, as you can see represented by this little vial of blood. And then in this case, not something we necessarily routinely are doing for our patients today, but they used urine and a hair specimen to check for ethyl glucuronide, which is a metabolite of alcohol. And what they found, and I think the take-home message of this study, was that up to 29% of those patients who were felt to have MASLD, previously called NAFLD, and about 25% of those with previously termed MAFLD, but basically your patient who has metabolic comorbidities and the potential for alcohol, are at risk of alcohol-related liver disease. So these patients, that alcohol metabolite showed at least a quarter, potentially a little more, of those patients were at risk of alcohol-related liver disease, in addition to the known metabolic or steatotic liver disease. So like with any disease state, there are some gaps in our assessment as providers of MetALD. As we've mentioned under that overarching term of steatotic liver disease, we know the cardiometabolic risk factors to screen for and to look at when we're examining a patient and trying to figure out the underlying etiology. But when we start to see a patient who has only isolated hypertension or hypertriglyceridemia, there's some additional questions that may come to mind. It's important to ask yourself, is alcohol also playing a role in this patient? If the answer is no, and you're pretty confident of that, then they may just have a single isolated cardiometabolic risk factor and they simply may have MASLD. However, if there is concern for alcohol, then it's important that we start to think about how are we going to quantify the degree of alcohol use. And that's where we're not taking hair samples or urine samples, but we are able to obtain a serum PEth test. And that PEth test is important because it helps quantify the amount of alcohol, and it allows us to detect potentially undisclosed alcohol use that may exacerbate our patient's liver disease. Whoops, I'm going to go back for one moment. As we look at the serum PEth test results, we can see that when the PEth falls in the realm of 25 to 200, we may be suspecting the MetALD picture. When it's much higher, and we may be suspecting that this is more an alcohol-associated liver disease, and certainly we want to exclude any other diagnoses in our differential. So in our patient, Ashley, we did a PEth test, and it comes back as 120, which is suggestive of that moderate to heavy alcohol consumption. As I mentioned, PEth is a biomarker for alcohol. It's kind of the idea of checking a hemoglobin A1C, which is our 3-month report card in our patients that we're trying to monitor their blood glucose. In this case, it looks at alcohol consumption over the prior 2 to 4 weeks. It often can indicate at least moderate daily drinking versus binge drinking. And in this case, the PEth in this graph we're looking at today was detectable for 3 to 12 days after one single binge. So that's an important part of the history if your patient's able to disclose to you, are you drinking daily or was this a one-time event and this is in isolation? I think it's important as providers that we understand there really is no significant variability in a patient's PEth based on sex or BMI. So it doesn't, there's no variability between men and women, and there's no variability based on your body mass index. This is an additional study that looks at alcohol use in individuals with excess weight. And there was about 659 patients who were screened for the study. Initially, 617 patients were enrolled. And the actual number after exclusion for patients who had no alcohol intake or were missing data was about 333 patients. They did serum PEth tests, so they utilized that biomarker we're discussing today. And they found that out of those 333 patients, that 97 of those analyzed patients had suspected MetALD. So this suggests that 15.7% of just patients, all comers with excess weight, were actually at risk for MetALD. So as we return to our patient, we see that she has multiple cardiometabolic risk factors. She also has that 2-glass wine admission per day. But she had, as you saw, alcohol intake and also the hypertension and the hyperlipidemia. And I think it's important to understand that alcohol has a biphasic effect on a patient's blood pressure. So it initially decreases the patient's blood pressure up to 12 hours after consumption. And then it increases their blood pressure greater than 13 hours after consumption. So as you recall several slides ago when we started to think about our workup for that steatotic liver disease, and we have a patient who has isolated high blood pressure, that's where it's important to start to think about, okay, does this patient truly have cardiometabolic risk factor and they truly have hypertension without the role of alcohol, or is their blood pressure elevated when they come to see you in clinic And it may be a result of the role of alcohol. Likewise, when we look at alcohol and hypertriglyceridemia, we see that patients were looked at and their triglycerides, their mean plasma triglyceride concentration was examined in two groups. It was the group who had 2 standard drinks of alcohol versus water. And as you can see, those who had the 2 standard drinks of alcohol had elevated triglyceride concentration over the 10 hours after administration. So you really want to tease out isolated hypertension and hypertriglyceridemia as to whether there's a role of alcohol in those elevations. So we've talked a lot about our patient. We have really shown she has elevated liver transaminases, steatosis on ultrasound. She has concern for pretty advanced liver disease. She has a positive PEth and the admission of 2 alcohol drinks a day, multiple cardiometabolic risk factors. And so I think it's pretty safe to say she has MASLD with a predominant MetALD picture. So both the metabolic piece as well as the alcohol piece. And so how can we go about our approach to treating this patient with MetALD? I think it's important that the patient work on lifestyle modifications. We, as a sort of overall liver societies, EASLD and AASLD, recommend the Mediterranean diet, obviously minus the wine piece, recommend adequate exercise and weight loss. I counsel my patients, especially someone with that more advanced fibrosis, to work towards that 7 to 10% total body weight loss initially to help reverse that steatotic liver disease and over time hope for some histologic regression versus the alternative, which would be progression to cirrhosis and potentially that liver decompensation over time. We could consider Resmetirom for this patient, our newly approved drug that's indicated for stage 3 to 4 fibrosis. It's our liver targeted therapy that essentially works by defatting the liver. And in terms of alcohol, we would recommend complete cessation for this patient. So I don't think there's really any alcohol that would be safe in a patient who has stage 3 fibrosis with elevated transaminases, and we are trying to reverse the underlying etiology versus result in further disease progression. I often say to my patients, it's often like having a little brush fire in your backyard. Your liver is inflamed and now you're going to dump some gas on top of it. And I think that image is kind of, patients can sort of grasp what we're referring to. So we don't want to lead to further inflammation. Does she need screening for HCC? My recommendation would be yes. So we know she has advanced fibrosis. She's in stage 3 according to that FibroScan, but would recommend that she have an ultrasound and AFP tumor marker every 6 months. So in thinking about the future and possible trials for MetALD, there's a few things that would be helpful. It would be great to base this investigation on objective biomarkers. We all know as providers that patients often underreport their alcohol use. It would be wonderful to have a way of standardizing that assessment of recent alcohol use, and that's where that PEth may be really important. And then certainly to show complete alcohol abstinence would be helpful if that was based on a biomarker. You want to ensure that drivers of liver disease are present. So we know that in the field of liver disease, and particularly with patients who have alcohol use or metabolic dysfunction, there can be improvement. There can also be progression or addition of new cardiometabolic risk factors. And so you want to ensure that you know which underlying liver disease etiology is present. You also want to look at whether a patient who stops alcohol use, does that resolve their hypertension or hyperlipidemia, or is it still present supporting the metabolic dysfunction? And then finally, you want to consider exposure to risk factors. So you want the patient to be fairly stable and meet that criteria during the last 6 to 12 months. So some take-home messages today. First and foremost, we have that new definition of MetALD, and it includes the alcohol intake in females of greater than 140 grams a week, and in males greater than 210 grams per week. There is the reality that clinical criteria can underestimate MetALD. So sometimes even with our best intentions to try to ascertain the amount of alcohol from our patients, we know that it's a very sensitive topic that patients often don't want to fully disclose and be transparent. And so that's where use of biomarkers and potentially further development in this realm in the future, use of that PEth are very helpful. As I just mentioned on the last slide, we want to ensure the drivers of liver disease are present and reassess that metabolic dysfunction over time. Consider adequate exposure to risk factors. And ideally, there would be criteria for clinical research that would facilitate an objective MetALD diagnosis, allowing for comparisons among different sociocultural realities. So I hope that you've gained an understanding of different etiologies of steatotic liver disease, and that you've been able to drive home the idea that we don't want to miss the role of alcohol in our metabolic dysfunction in steatotic liver disease patients. It really becomes an additive or synergistic player in creating worsening of their disease. I think it's important that we understand whether the underlying cardiometabolic dysfunction is truly cardiometabolic dysfunction versus whether alcohol is playing a role in that. And the hope is that over time and with more research, we can have ongoing use of biomarkers such as PEth to standardize this disease state among our patients and for providers. I'd like to encourage you to visit the GAP MASLD MASH Community Network for additional disease state education and a Resmetirom webcast. And certainly you can scan this QR code to complete a short survey and share your thoughts on today's presentation. Any insights can help us improve over time. So thank you for coming today, and I'm happy to answer any questions if you have them.